Welcome to my second Unit 4 video essay. All right, so let's explain all of the membranes, pressures, and mechanisms that make negative pressure and ventilation possible. So humans do negative pressure ventilation. And to start, we need to understand Boyle's law, which states that increased volume is going to decrease pressure, and decreased volume is going to increase pressure. So that's a gas law. And we as humans take advantage of this by using our diaphragm, pec major, pec minor, scalenes, and then external and internal intercostal muscles. So on inspiration, let's start with some pressures though. So the pressure of the atmosphere is like 760 millimeters of mercury, or 0. And then inside the lung, on inspiration, or at rest, it's going to be just a little bit less. It's going to be about 759, so that we have that pressure gradient for air to enter into our lungs. And then, so some anatomy of the lungs and thoracic wall. So we have our lungs, they're coated by visceral pleura. We have a pleural cavity with pleural fluid in it. And then we have the parietal pleura, which lines the thoracic wall. And then these membranes secrete this pleural fluid, which is going to help prevent like friction and rubbing of the lung on the thoracic cavity. So it just helps us to be pretty fluid with our breathing. And then what's going to happen is when we inspire, diaphragm moves down so the diaphragm is going to move down. The external intercostals are going to pull our chest wall out. And then our sternum is also going to move outwards. And this is going to increase the volume in the thoracic cavity, which according to Boyle's law is going to decrease the pressure. So now this is going to draw air into the lungs. And now we have our pressure of the pleural cavity, or our like transpulmonary pressure, which is like 754. It's always more negative than the pressure of the lung and the outside, because we need that negative pressure that's going to pull the lung out and keep it from collapsing. And then, so yeah, that change in pressure is going to draw air into the lungs. And then when we expire, the diaphragm moves up, decreases volume, and then our lungs have a naturally elastic property. They have this protein called elastin, and the lungs are a naturally elastic tissue, right? So they want to assume the smallest size possible. So on normal exhalation, most of our increased pressure and decreased volume in the lung is going to be caused by that elasticity. And then that is going to create, so since we're decreasing in volume because of elasticity, we're going to increase pressure. And our pressure in the lung is going to be greater than our atmospheric pressure. So we're going to breathe out. And now we have something called a pneumothorax here. And this is where the pressure, the negative pressure of the chest cavity is going to equalize with the atmospheric pressure, right? So our transpulmonary pressure, or our pressure that's inside the thoracic cavity, is always negative. But if we have something such as a puncture wound into the chest, then what's going to happen is the pressure is going to equalize. So we see that 0 is bigger than -5. So the pressure gradient is going to bring air into the lung, and that's going to get rid of that negative pressure, which is keeping our lungs from collapsing, and it's going to collapse that lung there. Because in a pneumothorax, you don't have that negative pressure that is sucking this lung out. That's gone. So the lung just has its naturally elastic, tendency to collapse like that. The lungs want to collapse. So when there's not that negative pressure, it is going to just go ahead and collapse. Okay. Let's see. All right, so what is surfactant? So surfactant is an amphipathic, meaning it has a head that is hydrophilic and a part that is hydrophobic. It's an amphipathic lipid protein complex that is going to decrease the surface tension inside the alveoli. So what happens in our alveoli is we have an air-water interface. So there's some air in our alveoli due to humidification and mucus. Or there's some water in our alveoli due to like humidification. And of course there's air in there, right? And at that air-water interface is going to create surface tension, where those water molecules are attracted to each other, and that is going to work to collapse the lung, or it's going to work to increase elasticity, right? So Laplace's law is a law of physics that states that the pressure is equal to 2 times the surface tension over the radius. So if we have high surface tension, then we're going to have high pressure, and if we have a high radius, we're going to have lower pressure, right? So surfactant is going to decrease our surface tension, which is going to decrease our pressure, and then that is going to decrease the work that we need to do to be able to breathe, right? So if we don't have surfactant, we have a lot of surface tension, a lot of elasticity. It's going to be easy to get air out, right? Because we're elastic, we can just push that air out. But it's going to be hard to bring air in. All right? It's going to take more work to overcome that extra surface tension and to get air in. So we'll have to have a higher respiratory rate, incorporate accessory muscles to be able to bring that in there. And then additionally, if we don't have surfactant, you know, our alveoli are different size, right? So we're going to have alveoli that are going to be underinflated and then overinflated. And then surfactant is going to combat this by, in our smaller alveoli, we're going to have more surfactant, and we're going to have less surfactant in our bigger one. Let's see. Okay, let's go over the alveolar gas equation now. So the alveolar gas equation states that the partial alveolar pressure of oxygen is equal to the fraction of inspired oxygen times the atmospheric pressure minus the partial pressure of water, and then minus the partial arterial pressure of CO2 over the respiratory, let's see, over that R value there, which is the respiratory exchange ratio. So to explain this a little better, why this would be important clinically is for putting people on oxygen, right? So if we have a low amount of, so say somebody has a low P big A O2, then what we can do is we can increase their fraction of inspired oxygen by putting them on supplemental oxygen to be able to increase that PaO2 so that we can better oxygenate the tissues, right? Okay. And then moving on, let's see. So how are CO2 and O2 transported in the blood? So in the alveolus here, we have our O2 and our CO2. And then we have, so in the alveolus, there is a gradient, there's a pressure gradient for oxygen to leave the alveolus and go into the blood and then be transported. And then there's a gradient for CO2 to come out of the blood and then into the alveolus to be exhaled, okay? And we use hemoglobin to do this, all right? So 98% of oxygen is bound to hemoglobin, and then 2% of it is going to be dissolved in the plasma. And then 70% of our CO2 in the blood is just going to be dissolved as bicarbonate. 23% of CO2 is going to attach to hemoglobin, and then 7% is going to be dissolved in plasma. So we have a rule called the Haldane effect, which is basically oxygen's effect on and CO2 binding to hemoglobin. So up here at the alveolar, at the pulmonary capillary, we have more oxygen coming in than CO2. So we're going to have more oxygen binding to hemoglobin here. But then when we get down into the tissues where we need that oxygen now, what's going to happen is there's a lot of CO2 coming out, which is going to cause it's going to cause hemoglobin to enter the T state and cause oxygen to fall off. And then and then CO2 is going to bind. So oxygen falling off of the hemoglobin causes CO2 to bind to it. Okay. So then we have our hemoglobin dissociation curve here. So what this is saying is that basically you can have a pretty big change in the partial arterial pressure of oxygen before your hemoglobin saturation starts to drop, right? But when it drops fast. So when our pressure is up there in the pulmonary capillary at 104 pressures, at 104, we're going to have about 98 to 100% hemoglobin saturation. And then we start to get out into the tissues, and then where our partial pressure of oxygen is dropping. And then once that drops, it's going to drop quick, right? So some factors, and this is all dependent on the T state and the R state of hemoglobin here. So with our right shift, so we can shift this curve, right? And some things that are going to cause, what a right shift means is that for whatever partial pressure you have less hemoglobin saturation. So some things that can do that is going to be an increased CO2, which is going to cause an increase in hemoglobin turning into the T state, which is going to release oxygen. You can have an acidic pH, which is also going to cause the T state, which releases oxygen. And then you have 2,3-DPG, which also induces the T state. You can have exercise, which is going to increase CO2 release and lactic acid release from the tissues, which is going to cause oxygen to leave the hemoglobin. And then an increased temperature is also going to cause oxygen to leave the hemoglobin. And then to get a left shift, we just reverse all these. So a decrease in all of these will cause more oxygen to be bound to hemoglobin. So like decreased CO2 is going to induce the R state, which has a high affinity for oxygen. Decreased pH, once again, is going to induce your R state, which is going to allow for a higher binding affinity of oxygen. All right, and looks like that's everything. So thanks for watching.